given. Okay, good evening, everyone. Our guest speakers, Dr. Segule, our moderator, and also our participants, audience, and importantly, the members of the clinical care platform. Thank you once more for joining us this evening for our webinars. Today, we have a 2-hour webinar which will look at the impact of HIV on COVID-19, breast cancer, and pregnancy. This is the outline, just to say thank you very much for joining us. You are all warmly welcomed, and I hope that this would be a very informative and engaging session for you. As always, just to remind you why the platform exists. It is to improve patient care through educational resources, through webinars like this one, some of the educational programs, but also the dissemination of evidence-based information that will enhance your clinical practice and competence, and ultimately, improving the way we care for our patients. Just as quick information to say, remember that for you to qualify for a certificate, you need to have joined via Zoom. Whilst we stream these sessions via other social media platforms, we can only issue certificates if you join Zoom, because we're able to account to the councils. Certificates are generally issued within 48 hours, so please be patient with us. You also need to attend for not less than 60 minutes for you to qualify for at least one CPD point. For any inquiries, you may send us an email at info@clinicalcareplatform.com or even visit our website right there. Just to say that we still have work in progress. Our drug-resistant TB course has been completed. We have now added the basic surgical skills course, which is part of the 8 courses that would be launched in the new year, together with some of the preparatory courses for those who want to do diplomas or even your part 1s and part 2s if you are planning to go back to school. So please be on the lookout for these particular courses. We are looking forward to welcoming you as official members of the platform. You can either join the membership on a 1-year or even 2 years option. So please do join in so that you can enjoy some of the benefits. Note that these webinars will continue in the new year and will be accessible whether you are a member or not. You won't be impacted. However, members will be eligible for certificates, CPD points, and also free courses and discounted course prices. Some of the benefits why you should consider being an official member is that you'll be able to maintain, your professional development. You'll be able to save money. You won't need to spend a lot of money, as most of the content will be made freely available to you. You'll get significant discounts for some of the paid courses. You'll have access to our free content. You'll always stay updated, with evidence-based guidelines and tools that you would need. And it's also flexible because you can decide anytime which sessions, which events you want to attend. So I'm hoping that you will consider supporting us so that we can continue to bring you the best webinars in this class. So today's webinar, we are going to discuss the impact of HIV on COVID-19, breast cancer, and pregnancy. The theme really trying to align with the World AIDS Day, with celebrations which are going to be commemorated tomorrow. The rationale behind this webinar is that we want to discuss the impact and the relationship between HIV and COVID-19, HIV and breast cancer, and HIV and pregnancy. Through this webinar, as a platform, we like to provide an opportunity so that we can discuss, and you can also understand the latest evidence such that we can improve the care for patients. Today, we've got 3 presenters, Dr. Magagula, Dr. Pakati, and Ms. Ngoma. I'm going to then hand over to Dr. Joshua Segule, our moderator, to welcome you, and then importantly, to also introduce our first speaker. Thank you, Dr. Sugule.
Thank you, Dr. Mawela. Yes, indeed, we appreciate the clinical care platform. And good evening, ladies and gentlemen, attendees, panelists, and to you as a host. It's exactly 18:06, and we have at least over 172 in attendance. And we are live on our weekly clinical care platform webinar. And I'm your host today, as introduced, Dr. M.J. Sugule. The National HIV Strategy in 2020 had looked on updates in the following statements, with the following statement in mind. There's still an HIV epidemic. It remains a major health issue in South Africa. Most people can live long, healthy life with HIV if they are diagnosed and treated timeously. For various reasons, certain population bear a disproportionate burden of HIV. People across the nation deserve access to tools and education to prevent HIV transmission. Every person diagnosed with HIV deserves immediate access to treatment and care. These updates allow for opportunities to refresh on the ongoing work in HIV research, care, prevention, and research. In the key areas which are critical for the next years, this will include widespread testing and linkage to care, broad support for people living with HIV to remain engaged in comprehensive care, universal viral suppression among people living with HIV, full access to comprehensive PrEP services. The vision, barely or mainly for South Africa, is that it will become a place where new HIV infections are rare. When they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic status, will have access to high quality, life-extending care, and free from stigma and discrimination. The World Health Day was first observed in 1988. Each year, organizations, individuals across the world bring attention to HIV epidemic to increase in HIV awareness, knowledge, and speak out against HIV stigma, and call for an increased response to move towards ending this HIV epidemic. So as the clinical care platform, we have joint ventures with the national organizations, programs to improve awareness on this epidemic, and bringing to you live through our webinar this evening. We'll be covering the 3 HIV-related topics, as Dr. Mawela has said, that continue to be a challenge in our healthcare system. Though our focus today is more clinical, we hope it will add more value in gaining awareness. Through our wonderful and powerful speakers in our clinical care platform, today's 3 topics will be focusing on HIV and in pregnancy, HIV and breast cancer, HIV and COVID. And to unpack it for us, our first speaker is Dr. Billy Magagula, who is a specialist obstetrician and gynecologist in both public and private sector, managing women during pregnancy and outside pregnancy. He has a special interest in gynecological oncology. His qualification includes Bachelor of Medicine and Surgery with Medunsa, Diploma in Obstetrics, South Africa, Masters in Obs and Gynae, UP, Fellowship of College of Medicine with Obstetrics and Gynae, South Africa, and Diploma in HIV Management, South Africa. Dr. Magagula, good evening. The floor is yours. Thank you.
Evening, Dr. Sigala, for the wonderful introduction, and evening to the panelists and the participants. Quickly going to share my screen. All right. I'm assuming that it's all clear on your side. So yeah, the topics, are very important. I'm briefly going to speak about something towards the end of my talk that is not really part of the topics as has been put for the webinar. But the basis is basically HIV and pregnancy. This is the Antenatal Survey. As you can see, HIV remains an issue in the antenatal period, so about 30.7% prevalence. It's been steady, of course, from around 2005 until currently. And I must say that we've made a lot of progress with our prevention of mother-to-child transmission in South Africa at less than 2%. So our guidelines are well renowned, and they are very much excellent. We've got the medication and the best healthcare workers looking after women in pregnancy with HIV. All right, so most importantly, just a few slides, I must say, on the key issues that are important when it comes to HIV and pregnancy. So before a woman becomes pregnant, they have to be tested for HIV. And those that are HIV negative, make sure that they remain HIV negative and take the necessary precautions. And for those that test positive, we need to ensure that they are put on antiretrovirals before conception, ideally for at least 6 months and with proof of virological suppression. And then, of course, we have to screen for opportunistic infections, which is part of the basis of ART care. And then we have to optimize. Remember, HIV is one medical condition, but there's several others that have to be dealt with. One major one currently that we're battling with in South Africa, it's obesity. So that also has to be addressed, and all the other lifestyle diseases that we do find in the preconception period. I must say that in South Africa, this is probably worldwide as well. It's not our biggest strength for us to have a preconception care clinics or preconception care. Women would come and just discover that they are pregnant, but they've never been seen by a healthcare worker in planning for the pregnancy, except if there's issues of infertility. Usually then we are able to do all of the things that I've put there. The one very important intervention preconception is the use of folic acid. We know that it prevents or reduces the risk of neural tube defects. So it's very important for a woman to start folic acid as they are planning to conceive. And then there's issues on the type of ARVs or antiretroviral therapy that can be used on a woman that's planning to fall pregnant. And I can safely say that all of them can be used. Our general first line, which is dolutegravir based, has been shown to be actually safe, and women can use that if we were to initiate them on antiretroviral therapy before pregnancy. And these are the pillars adopted by WHO, the South African HIV Society, and of course the South African National Health Department. So the first pillar is to make sure that women of childbearing age don't get HIV. So safe sex practices, male medical circumcision for their male counterparts, the use of condoms. There's also now the use of PrEP, pre-exposure prophylaxis, which I have a slide on in the subsequent slides. And then, of course, if she's HIV positive and she does engage in sexual intercourse, ensure that they have access to safe and reliable methods of contraception, many of which are widely available and can be used with antiretrovirals. And if she falls pregnant, make sure that we put all the necessary steps to prevent transmission to the baby, and ensure that both mother and baby are linked to care and they get continued care as they continue with their post-pregnancy life. And then the basis of now PMTC team during pregnancy for women in the antenatal period that are HIV negative, the current recommendation is that each month they have to be tested for HIV. We do get women that seroconvert during pregnancy, of course, with different exposure methods to HIV. It could be sexual intercourse or any other means. And that is why it's important for women in pregnancy to continue using safe, practicing safe sexual practices practice using condoms and be safe throughout the pregnancy. And those that are diagnosed as HIV positive, they have to have viral load monitoring. There's guidelines, the PMTCT guidelines 2019, they were updated in January 2020. They do have guidance as to when should we repeat viral load after initiating, as well as if the patient has been on long-term or lifelong antiretroviral therapy, when to repeat. There's even an algorithm in a case where there's no virological suppression as to how we should go about it. But because in the public sector we use the NHLS, it's very important. The funding for HIV is different from your general patients. So we need to be able to communicate with the lab so that they can direct the funding accordingly and know why we are actually doing these tests, particularly because we'll be repeating them quite frequently during the pregnancy. So the gatekeeping codes that have to be used when the woman is still pregnant and not delivered yet is C#PMTCT, and post-delivery, as we do the delivery viral load, it's C#delivery. I think for the colleagues who are in the public sector, always remember that for women that are HIV positive and you'd like to do your viral load, you must use these codes. Otherwise, the lab will also gatekeep and you might not get the results. I've mentioned and spoken about the safe sexual practices in the antenatal period, as well as after the baby is born, very, very important. And issues of delivery, there's the 2019 guidelines. I didn't think it was necessary for me to sort of present the whole guideline, but I'm quite certain that colleagues have gone through that guideline. It's very important. Viral load monitoring, very, very important. And that will also guide how we actually assist with the delivery process, minimizing your vaginal examinations, avoiding rupturing membranes unnecessarily. And if you can avoid instrumental deliveries, definitely avoid that. And remember the birth PCR for the baby and guidance as to what infant prophylaxis to be given, based on what risk the mother is classified as, either high risk or low risk. There's a whole big topic or talk about that. Another key issue that very controversial in the last couple of years, we always say, dolutegravir is going through what efavirenz went through many years back as ARVs were being introduced. There was a time where we could not give efavirenz in pregnancy, but subsequent studies came through and proved that actually efavirenz is very effective, it's safe, and it can be used in pregnancy. So yeah, dolutegravir was also tried a bit. So there was a study, the TEPAM study done in Botswana. Initial findings suggested that there was a 0.9% increase risk of neural tube defects if a woman was actually using dolutegravir in pregnancy. And hence the guidance that followed thereafter was that we should ideally counsel women about this potential risk and also not initiate them if they are in the early first trimester, less than 6 weeks. But the Department of Health has since reviewed all the available evidence, as well as the latest findings from the same study done in Botswana, which is a landmark trial, that basically showed that the risk ratio or the risk for neural tube defect is not actually increased by the independent use of dolutegravir. So there's no statistically significant difference between women who are exposed to dolutegravir and those that are exposed to efavirenz, meaning we can safely use dolutegravir in pregnancy. And yeah, it's a wonderful drug. At the time when we were going for exams, it was a hot topic to say what are the advantages of dolutegravir. And then one could actually list a few: high genetic barrier to resistance and tolerable side effect profile, and very rapid viral load suppression. So quite a few benefits, and the fact that the woman can actually use it when she is not pregnant and she's using other contraceptive methods. And together with TB drugs as well, it can be used, but the dose would have to be increased. So it's actually a very wonderful drug. There's a lot of research that's going on currently, when it comes to long-term or prolonged release injectable ARVs. Hopefully we'll get to that so that our patients don't have to take daily dosages species of antiretrovirals. But for now, we know for sure that dolutegravir can be used safely in pregnancy, and it is not contraindicated. Another issue, which I think it's very important, as we want to ensure that women who are HIV negative remain HIV negative in the pregnancy, and even when they are breastfeeding, it's the use of PrEP. PrEP has been shown to be very safe as well. It's actually the first two agents that are on our first line, tenofovir, emtricitabine. So it can be used, and I think obstetricians must be aware. And as we always inquire, when we test the female partner, the male is usually there, and we do offer to test them. So PrEP is available, and we use Truvada for that. And there's a paper by ACOG as far back as 2014 that identified those women that should consider using pre-exposure prophylaxis. And this is in line with the recommendations by the WHO, as well as our South African HIV Society. So it's safe, it can be used, and there's a guide or a protocol as to how one should use PrEP, and baseline bloods, and excluding TB, and making sure that this woman is tested for HIV every month, and monitoring their renal functions, as tenofovir we know can be nephrotoxic. So yeah, I think the take-home message when it comes to PrEP is that we should strongly advocate for women to take it if they fall into those categories that are mentioned there. And I think the other elephant in the country that I thought I should, bring it into my talk as an advocate for women's health, well-being, and women's rights is that, we unfortunately celebrate, or speak about the 16 days of activism for no violence against women and children in South Africa. But this should actually be a daily discussion. This should be, it's something that we talk about all the time and advocate for all the time. South Africa is not very friendly to women. South Africa is not very friendly to children, with one of the highest femicide rates. It's horrible when you watch the news, and I think it's everyone's responsibility to always, advocate and fight against gender-based violence and abuse of children. So there's an organization, they call themselves Women Deliver. They're actually quite passionate. They advocate for women's rights and ensuring that the woman is empowered, her rights are protected, and she realizes her true potential. And I think they make a lot of sense. If we want to build South Africa, we need to protect children, we need to empower women. We know that women are the ones, that turn a house into a home. They raise kids. They make a village. They eventually make a country what it is. So we really need to protect and look after our women, not only by talking but by action. Women that are being killed are killed by people that we know. We've heard a woman screaming next door, and we just thought, it's okay. They are just having a little fight, and that woman is dead the next day. So these are things we know. These are people we know, and we all have to stand and protect women and children. And of course, if you empower a woman, you're likely to have a stronger family. You are likely to have more educated women, and that can only be good for the families, for the society, for the country. And yes, we become a prosperous country if we look after our women. So this is a paper by Dr. Gordon. It's an amazing paper. It's a beautiful read. She published it about 2 years ago. So this is basically practical steps that, as we consult with women, these are things that we should do, screening them for gender-based violence. So she divided the recommendations into 6 R's. So one, we have to realize that there's abuse that is happening in the relationship. So you're consulting with a couple and the man is dominating the conversation. He doesn't want to leave the room. The way that she interacts with him is very suspicious. We need to be able to recognize that there is abuse happening in this relationship. And in our consulting rooms, women should be able to actually have access to us and confide in us and tell us that the man that is in front of you there is actually not treating me well. And there's all tools and different methods that one can actually identify that there's an issue in this relationship. And yes, we have to recognize the impact that this abuse is having on the woman and her children. And we have to do a risk assessment, assess whether there's access to or there's use of drugs, there's use of weapons in this abuse. And it's our responsibility to do a proper clinical assessment, document those injuries, collect those specimens, and then of course refer, to the law enforcement agencies, psychologists, and social workers. And most importantly, remember, most women that are actually abused by the partner are very much dependent on the partner financially and otherwise. So one has to guide the woman to develop a crisis plan. So how will she escape? At what time or when, how must she get this money to leave this man, and for her to go to a place of safety? Does she have extra keys? Is she keeping some savings somewhere in case she now has to run? Who does she call when she's in trouble? So this is all our responsibilities, and there's lots of organizations that advocate for this and are easily accessible over a 24-hour period to women that are victims of abuse. And I think in conclusion, HIV, as we've seen, 30.7% is still quite a concern in the antenatal period. We have to eliminate mother-to-child transmission. It remains our priority, and we have to empower and protect women and children in our society. And it is our responsibilities on a daily basis, not just for 16 days in December. Thank you. That was me.
Thank you. Thank you. Thank you so much, Billy. And I know we gave you some time frame. I know you'll have loved to speak more, but indeed, yes, I agree with you. With the National HIV Strategy, we need to increase the education and the tools in terms of awareness of HIV transmission and prevention from mother to child. And certainly, yes, full access to comprehensive PrEP services, it's appropriate when desired, and it's advocated. One of the questions before you go was that, is it safe? And I think you have answered it, that it's very safe to give PrEP if desired in pregnancy. I do not see a lot of questions, but very powerful. Gender-based violence, it's a no-no. And thank you for the 6R. I thought that was very powerful. I do not have much of questions for you. I don't know if Dr. Mawela, do you have any questions for Dr. Billy Magagula before we release him? I understand he's got an emergency Caesar to attend to.
Yes, I know he's got an emergency Caesar to attend to, and hopefully he will be back immediately after that. But Dr. Magagula, as you leave the session, can you comment on how easy is it to communicate safe sex? Remember, if she's pregnant, we talk about safe sex in the context of gender-based violence. I saw a comment from one of the participants, Nombuso Mhlambi, saying, thank you very much for including gender-based violence. The whole thing about safe sex and GBV, what's your advice around how we can try and help women to communicate that to their sexual partners or husbands and boyfriends and so on? Thanks.
Fortunately, most of the time when we see the expectant couple, the partner would always be there. And as I said, verbal and non-verbal communication is very important. And I think as a healthcare practitioner, your first priority should be the pregnant woman. So you must have a very good trusting relationship with them, so that they are able to prepare you before the consultation. If you do have that bond and that, open communication, the woman will actually tell you before they come that these are my issues, I am coming with him, and then you already know, to set the tone of the consultation. So I think for me, the most important thing is make sure that the male partner is there, because they often don't listen to their partners when they get home with a message from the doctor. So if they are present and you and the woman have had this discussion, it is easy to ensure that the message is carried across and you can follow them up thereafter.
Thank you. Thank you, Dr. Magagula. Yes.
I think a second before you leave.
Okay, you want to deal with it, Segula, quickly?
Yeah. Dr. Magagula, there's another one before you leave. How do we help women to report their abusive partner, especially if she comes to you at the clinic beaten while pregnant?
Okay, how do we protect?
How do we help them to report these abusive partners, especially if they come to the clinic and being pregnant?
Yes. Well, if it's almost like a patient that comes, having been assaulted in casualty. So our responsibility, according to the CSRs, obviously, is to recognize that there is abuse happening, assess the risk, what type of weapon is being used, if there's a weapon, are there drugs that are used there, and then you do your thorough examination, from head to toe, collect all the evidence, involve the SAPS. They will bring you the kits, the J88 and the sexual assault kit if you need to collect evidence, safely collect that evidence properly and send it off, to the law enforcement officers. You have to involve your social workers, involve the psychologists. And there's things like the protection order. Remember, the protection order, you don't have to go to court for it. It can actually be acquired any time of day, and it's just a paper to say this man must stay away from him, from the woman. So I think according to those 6 R's, if you think about each one of them, one will actually know practically what to do, and it covers, everything from you counseling the patient, to examining the patient, to linking them to care. And remember also on the medical part of things, or medical assessment, is for us to test for STIs if she's been exposed to them, test for HIV, give a post-exposure prophylaxis if it's necessary, and of course to talk about things like hepatitis B and vaccinations and all that. So I think just follow those 6 R's. It's a very practical guide, and if you look at each one of them, it will tell you exactly what you have to do next.
Right, thank you so much, Billy. We appreciate your time. If you do manage to come back, please do, so you can join us on our Q&A session. Let me release you. Thank you so much.
Thank you so much. Have a good evening. Hope to join
right.
soon.
All right, good. Thank you. Moving right along, just a quick message from the chat from Dr. Titi Bohoji says, good evening, everyone. I just want to say thank you, Dr. Mawela. What you did on the HIV guideline for a short course was exceptional, beautiful indeed. As we continue to educate and share this information in our clinical care platform, Dr. Mawela, well done on that session. Moving right along from one gynecological condition to another gynecological organ, the breast. The platform itself took a bit of time in the last month during the Breast Cancer Awareness Month. We had several talks regarding the breast cancer. And
Dr. Sokole, are you still there? Dr. Sokole, are you able to hear me? I think we must, I see you are there, but I'm not sure if you are able to hear us. Dr. Sokole, unmute, otherwise.
And she has just completed her PhD. I hope you got the last part. She's a surgical breast head of unit in Charlotte Maxeke and Rafa Breast Healthcare Center, and she has completed her PhD. Dr. Butimelo Pakati, please, the floor is yours. Thank you.
Thank you.
Thank you very much, Dr. Sekole. Good evening, colleagues. And thank you, Dr. Billy Magagula, for such an informative talk and for advocating for the safety of women and children in our country. Thank you once again for this opportunity to touch briefly on the breast cancer and HIV. So my talk will essentially share about what is currently known as far as breast cancer and HIV are concerned. Breast cancer is the most commonest cancer and cause of cancer-related deaths among women globally. And in South Africa, it accounts for about 22% of all malignancies affecting women. HIV remains the global epidemic, with about 38 million of people being reported to live with HIV. In South Africa, more than 7 million of people are currently living with HIV, and South Africa was actually regarded as one country which carries the largest burden of the disease globally. And it was also regarded as one country that has the largest and successful antiretroviral treatment program globally. Of note is that currently only 62% of people living with HIV are on ARTs. However, this was before the implementation of universal test to treat, whereby all patients that are diagnosed with HIV ought to be put on ARTs, and this is regardless of the CD4 count or regardless of the whether they've got AIDS or not. So we hope to see this figure rising now that. Okay, there's a bit of a problem. Can you still hear me, colleagues?
You can continue. There's a bit of an echo. Samuela, can you deal with this echo?
I'm not sure what it is. Dr. Vidumelo, can you stop sharing and then maybe reshare again? It might be bandwidth or internet speed. Let's try again. Okay, can you try speaking without sharing? I just want to hear if we still have the same.
Hi.
Someone has connected there, either via a phone. I see you've got two gadgets connected. You need to disconnect one. Maybe it's a phone. Okay, yes, you may continue. You may share your screen and then continue. Sorry about that. Thanks. Are you able to hear me, Dr. Vidumelo? Okay. Colleagues, just give us a few moments to see if we can resolve the technical challenge.
Dr. Mawela, are you winning?
Okay, let's give her a few moments to rejoin. In the meantime, maybe there is a question maybe which I can try and deal with from Sister Tembi Lavisa. She was asking that she wanted more information about the issue of weight and dolutegravir. And I think the easiest way to respond to this is to say, number one, the issue of patients gaining weight after being initiated on ARVs is not something that is new. So we know that most patients after starting ARVs would gain weight, firstly to their treatment weight, and also as a follow-up to that, then continue to gain weight, beyond that, which becomes a concern. Hence, when we approach weight gain and dolutegravir, we always talk about the importance of integrating, lifestyle modifications, screening our patients in terms of weight, BMIs, and also partnering with the dietitians around, health advice, food and nutrition, which is quite crucial. The last point which I want to say is that the issue of DTG and weight, it's still quite an issue that is, in the research field, trying to understand what is the actual, cause of this weight gain. I do know that the current literature suggests that actually dolutegravir is not necessarily the drug that is causing the weight gain, but actually it is the interruption of effervescence. So during transition, as you interrupt effervescence, patients get a rebound weight gain. All right. So yeah, I don't want to spend a lot of time on the issue at the principal level. Let's educate our patients about diet and nutrition, encourage exercise, monitor their BMIs, and then ensure that we continue to support them and take it from there. Okay, Dr. Bitumelo, are you back? Try to make sure that if you're using two gadgets, the other gadget is muted. Okay, thank you.
Hi, I'm back. Can you see my screen though?
Not yet. If you can try and share. But we do hear you loud and clear. Thanks.
We can't hear you. Okay,
That's coming through.
All right,
Thank you. We can see your slides, Dr. Bitumelo. Please unmute. Thank you.
Okay. I'll just continue where I left off. I think I was on slide 2.
Yes, that's correct.
Yes. So yeah, as far as the breast cancer and HIV are concerned, there've been several.
That's coming through. Thank you.
Thank you for that. As far as the breast cancer and
slides, please unmute. Thank you.
Okay. I'll just continue where I left off. I think I was on slide 2.
Yes, that's correct.
Yes. So
that's coming through. Thank you.
As far as the breast cancer, okay. I think I was on slide 2.
Thank you.
As
colleagues, I've asked Dr. Bitumelo to share her slides with me. I will then share from my side and help her with the slides. Thanks.
Are you winning, Dr. Mawela?
Yes, few seconds. Be patient a bit.
In the interest of time and in the meantime.
yeah, my humble apology to my colleagues. Yes, just to continue, several studies have been done as far as the breast cancer and HIV are concerned, and the studies were done both in the pre-ART era as well as the post-ART era, and so far they've been conflicting data. So we in 2014 we've embarked on the study looking at the actual effect of HIV on the breast cancer outcomes. Why did we embark on the study? It was mainly because, like I mentioned in my introduction, that South Africa carries the largest burden of HIV disease. So if there's any study that ought to be done as far as HIV is concerned, be it breast cancer, be it cervical cancer, any study where you're looking at the association between the HIV and that particular study, we believe that that study ought to be done in South Africa because we do have the data. So currently, what we now know is that HIV and breast cancer is actually regarded as a non-AIDS defining malignancy. Let's continue, Doc. Now going in depth regarding the effect of HIV on breast cancer, starting with the clinical pathological characteristics. what was initially believed was that the incidence of breast cancer was low among the HIV infected population. However, it is now clear that the incidence is actually the same. The incidence of breast cancer patient is similar among the HIV positive group as it is in the general population. So there's no increased risk. And when we, with regard to the age, we've observed that HIV positive patients, they tend to present at a much younger age compared to the HIV negative patient. Does that mean that when you are HIV positive, the chances of you getting breast cancer at a younger age is high? Not necessarily. We believe that this actually just reflects the demographics of the patients that are HIV positive. Like we all know that HIV tends to affect the younger group compared to the elderly. But I must also admit that the trend is starting to change now. With regard to the staging of breast cancer at the time of diagnosis, we've also observed that the HIV positive patients, they were diagnosed with an advanced stage of the disease compared to the HIV negative patients. What we've also noted was that HIV had no effect on the pathological characteristics of breast cancer, in that I'm talking about the histological type of the breast cancer, the grading, as well as the tumor biology. There I'm referring to the receptor status. And these findings were also confirmed by other studies that were done locally as well as internationally. Can proceed, Doc? You may proceed, Doc. Now, looking at the effects of HIV on the treatment of breast cancer, when we looked at the surgery, we realized that the risk of complication was similar among the HIV positive as well as the HIV negative patients. And in terms of the complications, we're looking at the local complications, the wound sepsis, hematomas, seroma, and also the systemic complications, like the incidence of PE, incidence of pneumonia. There was no difference between the HIV positive and the HIV negative group. So essentially, just because a patient is HIV positive doesn't necessarily mean that you must treat them differently. Obviously, before the ART era, this was not the case, but now because of the effectiveness and the availability of ARTs, we've seen the trend that those patients can be treated similarly. Now looking at chemotherapy, Ngidi et al., this was done in Durban. They actually found that the HIV positive patients, they were more prone to develop chemotherapy-induced neutropenia, and they were developing neutropenia at a much faster rate. Obviously, these findings were also, they correlate with what has been published locally and internationally. With regard to the radiation therapy, in terms of the completion rate, we found that this was actually similar between the HIV negative and HIV positive group. However, there are still studies that have been done looking at the actual complications of radiation therapy among those who are HIV positive. And yes, there's still ongoing studies regarding the effect of HIV and the hormonal therapy, especially the tamoxifen. So we hope to see the data once it is available. You may proceed, Doc. Now, looking at the effect of HIV on the overall breast cancer survival, we've noticed that the HIV positive status was associated with poor overall survival. This finding was similar to that was found in Botswana, as well as the meta-analysis that was recently published in the US, that HIV positive status is associated with poor survival. You can even see the first graph. And when you look closely among those who were HIV positive, we noticed that the HIV positive patients on ARTs, at the time of breast cancer diagnosis, they were associated with better overall survival compared to those who were not yet on ARTs. This was published in June this year. And next slide. Now, looking closely at the effect of HIV on disease-free breast cancer survival. Again, among the HIV positive patients, we realized that that those who were on ARTs, they had a better disease-free survival compared to those who were not on ARTs. And also looking at the HIV status, those who were HIV positive were associated with poor disease-free survival compared to those who were HIV negative. Next slide. Now, what is clear? What is clear currently is that the HIV positive patient, they tend to present at a younger age and also at an advanced stage of breast cancer. With regard to the latter, it's actually quite surprising because one may expect that someone who's HIV positive, that person is already in the health system. Already in the health system because they do regular follow-ups to look at the CD4 count as well as the viral load. So one would assume that the HIV positive patients, since they're already in the health system, they might be picked up, they might be picked early with breast cancer, but unfortunately this is not the case. I think also, this also highlights the importance of all the healthcare providers that every point of contact, when you see the patient, regardless of what the patient may be presenting with, it is also important that we examine the patient from head to toe, and as part of the examination, we check the breast, because yes, some patients might not even be aware that they might have breast pathology. So we must use this as an opportunity to be able to detect breast cancer at an early stage. And yes, we know that the HIV does not have any effect on the pathological characteristics of breast cancer. It is associated with poor overall and disease-free survival. And the ART use improves the overall as well as the disease-free survival. What we found interesting is that does the ART use have any direct effect on the actual survival or not? Because one may say, yes, patients that are on ARTs, yeah, they might have better survival because obviously when you're not in ARTs, you are more prone to have to develop opportunistic infections. Person might die from HIV-associated diseases and not necessarily breast cancer. So maybe that's the role that the ART is playing. But then now what we still need to find out was that the effect of ARTs on breast cancer specific mortality, we don't have that data at the moment, as well as what ARTs do in the tumor microenvironment to help us understand what does the ART do as far as breast cancer is concerned. I will stop here. Thank you.
Thank you so much, Dr. Boitumelo. We appreciate the information given and the good work that you are doing in Short Matege. Quite an important study that you presented to us. We really appreciate, and still part of breast cancer awareness. I think this was very educative, though short because of the time frame given and the glitch and the technicalities that we had. We really apologize about that. However, I'm not going to take questions for you now. I've got a few questions, about 4, 5 to 10. We'll take them after the last speaker has spoken in our Q&A section. And then I see not a lot of people have already posted questions regarding this, so we'll give them time also to pose their question regarding breast cancer and HIV. So I'll leave you for now as I turn back to Dr. Mawela. Please, it's your turn now, Dr. Mawela. Do you want to share something with us before we go to our next speaker? And we'll come back to you, Dr. Pakadi, in the next 20 minutes. Thank you.
Yes, Dr. Segole, mine is to encourage everyone to support the platform. We have our clinicians who spend, a great effort to support the platform so that we continue, to educate and to empower you. I have a short snippet of a video which I want to play for you just for 30 seconds. Is it audible, Sugule?
We can hear it's just playing, there's no volume.
Oh. I think my surprise is getting spoiled. Give me. Dr. Sugule,
All
let's
right,
leave it
thank you so
for
much.
the end.
Thank you.
Thanks. Colleagues, just support us. That's it. Thank you.
You can play it again with a better video at the end. I think it's quite an important video because we do still get those messages and questions as to how to join the clinical care platform as our members are increasing. People want to know. I think the video is the most effective way of showing people how can we join. Thank you so much. Yeah, you can play with the audio at the end, okay? Moving right along to our last topic of the day, interesting as well, like the previous two. It's a question that has been asked before in our clinical care platform. Is there any relation between HIV and COVID? I think it's hot. It's one of the debates in the context of COVID. And to unpack it for us this evening, it's our friend to the clinical care platform and also a member to the clinical care platform, uNobile Ngoma, who is a field epidemiologist with a research interest in antimicrobial resistance and HIV opportunistic infection, and has received 2 field epidemiology international awards in 2021. She has completed qualification in Bachelor of Clinical Medical Practice and Masters of Health Field Epidemiology and Training Program, which I so understand she got a degree cum laude. She's also a clinical medicine lecturer at University of Pretoria, a postgraduate diploma in public health tour, and she also a medical advisor on various SABC radio stations. And supporting her in attendance today is the members of WHO, NICD, and the Free State CEO of one of the districts of the hospital, Dr. Ramalwa, Helen Khatla, Kuliso Ravuhali, Imelda Ramochula, Ashley Chitaka, Siseka Mashele, and Dr. Madikana. We really appreciate your presence and the opportunity offered to give us a knowledge regarding this. Dr. Nobile Ngoma, please, can you share your slides and take us through? Thank you.
Good evening, everyone. I'm pleased to be back. It's been a while, but I always follow you guys, always. So today we're going to quickly look at the, I'm in the field, by the way. Before I continue with my talk, part of the way the speaker has just introduced me, we were allocated in Mpumalanga province. I think it's the best platform to even mention this before I go into my talk. So because of the province itself, it shows a relatively low, a very low actually vaccine rate, COVID-19 vaccine rate in the country. Mpumalanga province, among healthcare workers, we see a very low vaccine rate. So we're allocated to come and investigate during this week. So the members that I'm with, the NICD, WHO, and the provincial public health specialist, we are together you'll see us in your hospitals. We come in each hospital to try and talk to you and give you a survey to check on the perceptions and the feelings about the COVID-19 itself, as well as the COVID-19 vaccine, so that we can try and see where is the gap, where do you guys need assistance and all of that. So before I leave, I'm going to ask to also share the survey to those that we will not meet when we come to your different hospitals. So enough about COVID-19. Today I was asked to prepare 2 slides, maximum 5, on the impact of COVID-19 on HIV. So I just took the public health perspective to check in the impact of these colliding pandemics, because we know that COVID-19 had actually found the HIV and AIDS pandemic existing and living among us. So just to give a background that everyone knows in the call, so South Africa, we have the largest HIV epidemic in the whole world, as much as we do have the largest antiretroviral treatment program in the whole world as well. Although these 2 measures, they actually assisted us in seeing a little bit less AIDS death compared to the previous decades, simply because of this progress that have been made. Although we are still a bit worried about the incidence, the HIV incidence that is rising, especially the late diagnosis. We still see a proportion of about 32%, according to the UNAIDS 2019, of the people that come into our hospitals, they only get to be diagnosed after their CT counts, they had dropped less than 100. So now, looking at the pandemic and what it had done to these the existing HIV epidemic. So COVID-19, we know that we're not only worried about the high morbidity and mortality that it came with, but it also came with disrupting the essential systems for health. This had undermined so much the progress that have been made in terms of HIV. And we also know that the global HIV response is dependent largely on the international contribution in terms of the generic medicines. So the Global Fund to fight AIDS, tuberculosis, and malaria actually reported at the beginning of this year that the COVID-19 control measures, they resulted in poor timeliness regarding the essential health commodities, particularly the delivery of these medicines and other health commodities. So a 6-month, 50% disruption in HIV treatment was estimated to lead to about 300 and above thousand of extra AIDS-related deaths, particularly in the sub-Saharan Africa, because this is the area in the whole world that bears a higher morbidity and mortality of HIV infection. So this region, we know that according to our 2019 guidelines, again, we had seen just above 440 people that died of HIV-related illnesses. So again, the estimation that was conducted earlier this year had said the 6 months service disruption in HIV PMTCT programs will definitely result in a minimum of 40 towards 80% of the increased incident among these babies that will be born with HIV infection. So there's a study that has been conducted in KZN that looked at the holistic HIV services that are being rendered in our country, and therefore checking what are the differences that they could see during the COVID-19 pandemic. So the study has been recently published, but it was the study period was between actually during the 2020 pandemic. So it pointed out that ART provision was generally maintained better than what we had feared. Although there were disruptions, but it was generally maintained. But the large impact was seen when it comes to the HIV testing and ART initiations. So this will now take us to the increase that we have seen in the previous years of the late diagnosis. So they pointed out as well, they reported a 48% decrease in HIV testing in the first month of lockdown. So as we can see, the fluctuation of these disruptions, they are directly proportional to the hard lockdown. So they said after April, after the first hard lockdown, the HIV testing increased to about 18% per month. So this tells us that as I'm saying, that the waves are directly proportional to the disruption. So each time there's a hard lockdown, there's disruption to treatment, and disruption to HIV testing and ART initiations will consequently obviously lead to the virological failure, poor adherence, and latecomers into our healthcare system. So during the COVID-19 pandemic, that definitely gives result in a complicated clinical management to these patients. So the HIV pandemic has started quite a long time ago. So when we're looking into the good that it came with that we had to use during the COVID-19 pandemic. So at first, when the COVID-19 pandemic emerged, the early response to this pandemic, it was now guided by the HIV response experts that were already in the field and that were already experienced with pandemics. So the second thing is that we use the existing essential HIV infrastructure and policies because we already were experienced about pandemics. So we're able to leverage into our interventions during the COVID-19 period. Didn't have to like begin right from scratch, but they actually took off right where the HIV had already built. And just to mention that the HIV laboratory investments are driving the broad improvements in diagnostic capacity as we speak. So the third thing I wanted to point out is that the service model pioneered by the HIV response. So the pandemics themselves, starting with the HIV, then the COVID-19 pandemic, they actually showed us in the whole world that we need to invest in primary healthcare. We need to invest in community-led services way more than not way more than actually, as much as we do invest in the hospice center services. So we don't have to wait for patients to get sick and come to the hospitals, and then we get overwhelmed and all of that. So this model in South Africa, it came about the HIV epidemic when they were trying to control it. They came with an idea of building and investing so much into the community-led or community-centered services, the likes of community healthcare workers, the likes of CCMDDs and all of that. So those were all imposed or developed to actually try and decongest the healthcare clinics. So when the COVID-19 pandemics came in, we were able to leverage on those kind of model and services that had already begun through the HIV pandemic. So quickly looking at the progress that have been made, the positives. I couldn't put in everything because of the 5 slides. So looking at the related progress that we have made in terms of the HIV together with the COVID-19 pandemic. So the Moderna is now working on a vaccine candidate, for an HIV vaccine candidate. It's actually 2 of these vaccine candidates that they are working on. So we know that they had made a huge breakthrough in terms of the mRNA vaccines managing the COVID. And we know right now that the mRNA vaccine have a superior efficacy and protection compared to any other types of vaccines that we have. And the advantage with the mRNA vaccines is that changing the formula, the technology that they use allows them to change the formula easier in case of mutations. So they decided that with the progress that they have made during the COVID-19 pandemic, they're going to apply the same method and push into now trying to crack the HIV vaccine. So this is it's good progress. So again, we also have these 3 drugs that are FDA approved, not yet approved in South Africa by SAHPRA, that are used already at the States in treating patients with COVID, which include remdesivir and malnupiravir and Paxlovid, which is the Pfizer pill. So these are the drugs that are currently FDA approved and are used to manage patients with COVID. So I've attached a few references that I've used when I was compiling and thinking that it would be very interesting for clinicians to go and look at. And yeah, that's all for today. Thank you.
All right, thank you. Thank you so much, Nwabile. Quite precise, straight to the point. However, the questions are forever there. You cannot escape from them. I'm going to give you a minute so that you can breathe and take a breather and call all my panelists to come back. I've got a few questions for them. And I know as well as Dr. Mawela has a few questions for them. And our lovely attendees, they've got a lot of questions for you guys, okay? Dr. Mawela, can I have all my panelists back on the platform, please?
You have them. I think
Okay.
you have Dr. Pakati, you have Nwabile as well. I think Dr. Magagula is probably still dealing with the emergencies and he will rejoin us. But if there's any HIV specific questions, I can try and assist as much as possible. Thanks.
All right. Plus your special interest in gynecology will help us. Dr. Pakati. Nope. Bitimela. Dr. Pakati.
Hi, I'm here. Thank you.
Yes, with regard to your study, one of the questions that came up is maybe it's been missed. I'm not too sure. When you look at HIV positive and non-HIV patients, does HIV pose higher risk to get breast cancer compared to the non-HIV patients?
Thank you for the question. The answer is no.
So
the answer is no. Sorry?
They are equally affected.
Yes. So when you look at the incidence rate, is similar between it's the same incidence that you get in the general population, and also what is known is that HIV it's not a risk factor for breast cancer. And then we also observe, we know that HIV is not an oncogenic virus, but rather a permissive virus, which indirectly increases the risk of other cancers among the HIV positive patients. But what we know now that HIV is regarded as breast cancer is regarded as a non-AIDS defining malignancy, unlike the cervical cancer, which is an AIDS defining malignancy, whereby when you have HIV, you know you are at high risk to develop cervical cancer. But this is not the case as far as breast cancer is concerned. Thank you.
Oh, thank you. Thank you for that.
Dr. Segole, if I may just maybe say also, I remember very well that during the introduction of universal test and treat, in addition to the prevention of obvious HIV-associated opportunistic infection, a number of studies had actually shown that due to persistent immune activation and our bodies being exposed to inflammatory markers for prolonged periods, particularly in patients who have low-level viremias, and so on. There was some risk of patients developing non-AIDS associated malignancies, particularly if you look at prostate, lung cancer. Just that I can't remember if breast cancer was one of them. But maybe my follow-up question to that, Dr. Bidimelo, you did mention that most of living with HIV do present with cancer at a younger age, and that, but unfortunately, are presenting with advanced disease. And we know that these patients do present for care, on a month-by-month basis, most of them, or at least once or twice a year. What are your proposals around interventions that we can introduce as part of the HIV program to improve early diagnosis and care of our patients? Thanks.
Thank you for the question, Dr. Mawela. I think maybe let me start with the first point that you made. Yes, there was a belief that due to the effectiveness of ART use and the fact that now patients living with HIV, they tend to live longer, there was an expectation that we will see an increased incidence of the non-AIDS defining malignancy. In those studies, yes, breast cancer was one of them and prostate, but at the time they did not really see any change as far as breast cancer was concerned. And also from the studies that we've done locally, we did not really see an increased incidence of breast cancer among the HIV positive patients. Now back to what you're saying, I think if you remember, like my conclusion, that it's actually surprising to see that the HIV positive patient, they present at an advanced stage, because one will think patients are already in the system, they are already coming back for regular follow-ups. So it's possible that maybe that opportunity is not necessarily being used. So my advice would be that for all healthcare providers, when the patient presents, when you see those patients, make use of that opportunity as an opportunity for you to examine the patient from head to toe, including the breast. Do ask about the risk factors for breast cancer. Make use of it as an opportunity also to raise awareness, like for breast cancer and other malignancies. And I think that's one of the things that we can do. Like I also mentioned, that at the moment we're not really sure about the exact effect of the HIV in the tumor microenvironment. What does it actually do more at the genetic level? Obviously, there will be the publication on that beginning of next year, but yeah, currently it's not yet clear. So obviously, colleagues who are more interested in research, that's maybe like one area. The scientists, clinician scientists, that's one area that one can look into as to what actually happens in the tumor microenvironment as far as HIV is concerned. Thank you.
Thank you. Thank you for that. Dr. Segole, are you there? You might be having a network challenge. All right. Whilst we're still trying to figure out if Dr. Segole's network will come back, maybe a follow-up to you, Dr. Phakathi. With respect to patients, doing well on ART, is there any publication around the comparison between fully virologically suppressed patients in terms of, survival outcomes, and also maybe based on the clinical presentation of patients, whether they are already controlled? WHO stage 1 versus stage 4. So just on the survival, because your graphs mostly concluded on whether patients were on ART or not. So my interest is to check whether they are clinical stage or whether they are fully suppressed or not, whether that had certain implications for their survival. Thanks.
Okay, thank you for the question. Maybe let me start with the last one. So yes, obviously there's the staging, the stage of breast cancer at the time of diagnosis. We know it's a non-predictor of the overall survival. The more advanced the stage of the disease is, the poorer the overall outcome is, the overall survival as well as the disease-free survival. This is in general. What we did not find from our research is that the HIV did not necessarily have an influence on that, because we know the staging in general is directly proportional to the overall outcome of the patient. Now you ask about looking closely at those who are virally suppressed. The data is there. It's something that we can look into and be able to provide those results, but we did not look at that, but we do have the data. We shall make it available with our next publications. Thank you.
All right. No, thank you. Thank you very much for that. Dr. Sekola, are you back? Thank you.
Yes, sorry, my apologies. My question before I got cut was the histological distribution that you found in this HIV and breast cancer patients.
Okay, thank you for that. So what we found that was that the histological type of breast cancer was the same between the HIV negative, HIV positive group. The tumor grading was the same between the two groups. In terms of the receptor status, the intrinsic subtypes, it was the same between the HIV positive and HIV negative group. So our conclusion from that was that HIV did not have any effect on the pathological characteristics of breast cancer.
Oh, thank you. The last one
before. Just
yes.
before that, just to link it to a question from Pumla George. She is asking if there's any contraindication between ART and chemo. But my interest to add to that, Dr. Packard, is a question of most of the oncology units in the country would not accept a patient, for example, if they've got Kaposi sarcoma, one of the cancers in HIV, they would not accept a patient unless the patient is virologically suppressed and maybe the CD4 count is also, a bit higher. Now, Pumla is asking what are the contraindications of chemo. So what I'm trying to get to is that with breast cancer and chemo, do patients need to meet certain requirements, or how do you approach those? Thanks.
Thank you for the question. So among the HIV positive patient, it is advisable that before you send anyone, any patient for chemotherapy, it is important to know that the patient must be on ARTs, because we know the side effects of chemo. Chemotherapy on its own leads to immunosuppression. So it is important that the HIV positive patients are on ARTs. They've got, they are not immunosuppressed, because obviously imagine giving chemotherapy on someone who's already immunosuppressed. It will not work. It will not work. So the contraindication will be like someone who is immunosuppressed. So we advise patient must be, actually that's why that's how we treat our patient. Once we know that you are HIV positive, we send you to the HIV ART clinic for the initiation of antiretroviral therapy before you go for chemotherapy. So from the studies that were done, we know that the HIV positive patients, they are more prone to develop a neutropenia compared to the HIV negative patient. So that's that is just to make the oncologists aware that, as you treat these patients, be aware, be more vigilant that this patient is most likely will develop neutropenia simply because of the HIV status. So approach with vigilance, and in a case whereby you realize the patient is neutropenic, you can stop, you can supplement with Neupogen, or rather change the regime. Thank you.
Okay.
Right,
but then the good thing is that, okay, sorry.
That's fine. The good thing is what?
Unmute, Doc.
Sorry. Yeah, so I was just saying the good thing is that now that the ARTs are being made available to all patients who are HIV positive, so it won't be much of a struggle to, after we diagnose HIV breast cancer, then say go to ART. there won't be a case where now one must decide, do you qualify for ARTs or not? So we are actually excited that ARTs have been made accessible to everyone. So we hope to see even the change in the trend of survival as far as the breast cancer patients are concerned.
All right, good. Thank you. Thank you so much. Very informative and straightforward. I'm not too sure if your study looked exclusively at females, but there's a question if there is any relation of HIV to male breast cancer.
We looked mainly at women with breast cancer. As you know, that male breast cancer is there, but it's not that common. But there was a study that we did where we looked at the spectrum of male breast disease, and we noticed that among the HIV positive patients, male patients were more prone to have the gynecomastia. There were those who had a breast cancer, but obviously it was like only like few numbers. So it's something that can be looked into to see among the male breast cancer patients, how does HIV influence the progression of the disease or even the overall outcome?
Right, thank you. Thank you so much. We'll leave you for now. We'll come back later. I just have a question before I go to Nqobile that I'd like to pose to the floor. Think about it as we go to Nqobile. They say a pregnant woman present at the clinic with signs and symptoms of violence, in denial to disclose. How do we help in such case? This woman is in denial, she's been abused, and she's pregnant. How do we help? And Nqobile, are you ready? You can think about the answers. I'll get the answers later. We go to Nqobile. Nqobile, can you hear me?
Yes, I can hear.
Yes, very nice presentation. Well done. Thank you so much. You have focused more on the indirect link or indirect impact of COVID on HIV. However, I want to bring it a bit clinical and also challenging the platform and whoever is in attendance that may have answers to these questions so that we can relate this COVID to HIV. Have we seen a lot of hospitalizations in terms of HIV and COVID? Hospitalization more common in HIV patients, or is just normal patients, or it's equal across?
All right, so initially we didn't find so much of a link or a strong significant association between HIV and COVID. And it was even believed initially, some of the scientists were saying, because these patients are already on antiretrovirals, and this is a acute respiratory viral disease. So probably that's why we couldn't. But during the progression of the pandemic, like as it stands right now, we found out that HIV patients, particularly those that are not controlled, their viral load are actually less, and their viral load are actually higher, and their CD4 count are low. Those patients are prone to even to start by contracting the COVID-19 itself. And when they have COVID-19, HIV-infected patients, they have a higher risk of having severe disease, needing hospitalization, ICU, and dying. So yes, we do see quite a lot of patients that are actually presenting in the hospitals and even succumbing to COVID-19 that are HIV positive.
You've linked more towards those that are uncontrolled HIV, presumably that maybe they are defaulters or anything not controlled. What about those who are on HIV, who are HIV positive, but they are controlled?
The ones that are controlled, they are at risk compared to people that do not have HIV at all, but their risk is minimized compared to the patients that are not controlled. So as long as the patient is controlled and their viral load is lower than detectable and they're eating well, watching, abiding to the health control measures, then they are not as at a higher risk of actually contracting COVID and succumbing to the virus. But I just put an emphasis to say those that are controlled or those that don't even know that they have HIV, those are the patients that will come presenting with severe symptoms of COVID.
What could be the reason? Could it be because they are immunosuppressed, or could it be because they are on antiretrovirals? My question is, are antiretrovirals protective to COVID-19?
No, they're not protective to COVID-19. So now the patients, the reason why you would see the patients that are not even on antiretrovirals and are presenting with severe outcomes is because now their immune system is suppressed. Remember that COVID, it feeds itself on suppressed immunosuppression. So whether it's your diabetes, your hypertension, is your HIV, it's extremes of age, it actually feeds on immunosuppression. So when a patient is HIV and not on treatment, therefore their immune system is far suppressed to fight this infection. So that's why there'll be that discrepancy. But when a patient is now on ARVs, it's not like ARVs themselves, they are significantly protective towards COVID. But now, because their immune system now is optimum based on them adhering to treatment, and the treatment is working for them if there's no virological failure or poor adherence. So that is when you don't get to see most of them. It's simply because their immune system is able to fight the infection.
Oh, thank you. We have heard and we have seen, and scientists have reported that patients with immunosuppression, regardless, HIV, renal failure, cancer, breast cancer, or sort of anything of immunosuppression, they tend to have long-term COVID sequelae. How true is that?
That is very true. It's 100% correct. So the long COVID is associated with actually when a patient gets infected, it depends on how much viral load you're going to produce or the replication of the virus you're going to have in your body. So remember, if you're not vaccinated at all, you are at risk of producing so much viral load for you to be much sicker and transmitting the virus. So in that process, because you got sicker more than any other person with mild symptoms, you are prone at having or suffering from long COVID. So that is very much true. But I'll just emphasize that it depends or if you were vaccinated or not, if your immune system was strong enough to fight the infection or not. So your long COVID is mostly dependent on how much viral load you had. And that is dependent on your immune system at the stage of you contracting the virus.
Oh, thank you. Very clear and loud. Just lastly, in relation to that of long COVID and immunosuppression, especially with the recent mutations, is it true that if you've got long COVID, you are more likely to cause mutations, as it has been reported in the media, especially with our recent mutations?
No. So the risk of you producing or having the emergence of new variants is entirely dependent on the viral load. So we always link it to people that are not vaccinated. As I've explained, that if you're not vaccinated, your immune system is not trained to fight the virus. Therefore, you are automatically producing higher viral load than someone who's vaccinated. So during the viral replication, that is when the virus makes mistakes and errors and resulting in variants. So the variants are associated with unvaccinated people other than any other thing.
Oh, okay, thank you. Just to link the two between the pregnancy and COVID and HIV, one of the last questions for you, Nobile. I don't know if you've got an answer to this because Dr. Billy Magagula is not here. They say, can a pregnant woman transmit COVID to a baby? I think we had this question before in our platform. I just can't remember what was the answer. Can a pregnant woman who's COVID positive transmit it to the baby? Do you have any idea?
I do not have scientific evidence right now. I'm sorry, I didn't think of checking that, so I cannot give you a straight answer. The last time we checked, we had a suggestion that people could transmit it vertically, even you'd find it in a semen and all of that. So there was a possible transmission, but at this stage, I cannot give you a straight answer. I'll be lying.
Dr. Mawela, do you know anything about that?
Yeah, just to say a few things. One is that there are strict case definitions which then define what is a congenital COVID-19 and what is it that you would consider as just postnatal transmission. There have been fewer cases of congenital COVID-19 that were documented. I think Dr. Magagula's presentation in I can't remember, October, September, had those kinds of cases and also the actual case definitions. And then when we discussed it also with the dietitian, Ms. Maria van der Merwe, there's recommendations that babies must continue to be breastfed. However, we should make precautions and encourage mothers to get vaccinated, to always sanitize, also, use masks during breastfeeding to minimize the impact. And the babies generally do well. If you remember, the pediatrician was also in the group, speaking about that babies generally do well, especially if the mothers are vaccinated. These children have some partial immunity, especially if the mother opts to breastfeed. So really, I think that those are my comments. Maybe to Nobile as well. Firstly, to say thank you very much for presenting to us today. I wanted to talk to you earlier because I got a number of calls from a number of clinical associates. Some of them I see they have attended, as well. It's important, Dr. Sekule, that we transform and we continue to engage, a wider audience in terms of health professionals, allied health, everyone. This platform is for everyone. But Ncobile, just then few things. I just want to then ask you a question to say, considering that you have presented that we had fewer HIV tests being done during lockdowns, there was some level of limited access to treatment, especially, initiations. Is it possible that the association between COVID and HIV is rather mainly because of the failures of the public health response to maintain health services? Therefore, we had a higher population of people with higher viral loads not suppressed because of limited access to healthcare during COVID lockdowns and so on. Thanks.
Okay, in answering that, remember we said that these patients that are prone to severe outcome or yes, just not good outcomes because of HIV, it's particularly people that are not controlled. So we in our presentation, we had mentioned that we saw a significant disruption in terms of HIV testing and initiating treatment on time. But the people that were on treatment, there was not that much significant change or disruption. So not unless we're talking about the late diagnosis, which is a different issue on its own. So if people, they didn't know that they were HIV positive or they were in denial and not taking, they never tested or never initiated on treatment at all, then we would see that. But for now, I can't say it would be a confounding factor because it's not just in South Africa, it's a global phenomenon that is being seen and is consistent among all these regions.
No, thank you for that. Then as a follow-up, a very similar question. In the same period, you would have picked up that very basic services like TB screening, I think the overall TB diagnosis in the country, access to gene experts, we saw a significant drop in the number of gene experts. Is it possible that whilst we think it's COVID, what's the possibility that some of these patients would have had TB, which is undiagnosed, which we missed? I think also psychologically, health workers, if you were coughing, having fever, everyone was just thinking COVID and not thinking TB. I'm not sure if postmortems were that, but I'm just trying to get your inputs on some of these issues. Thanks. Yeah.
Okay, no, when these studies are being conducted, you control for confounders. So anything that is related to an exposure, in this case, an exposure is COVID-19, and an outcome is death or mortality or hospitalization. So anything that can be related between those two, they are always controlled for. So within your cases, which are people that are having an outcome of interest and exposed, and the non-cases, so between those two groups, you ensure that the characteristics should be similar so that you can now come with your conclusion to say, this is the reason why I'm saying what I'm saying. So the results themselves, I'll just share the study itself. I'll send it as a PDF right now after the session for you to see further. But my answer is that during the studies, we control for confoundings. So you wouldn't have made mistake to say the outcome resulted from another factor, because all these factors are being controlled for.
All right. So now, so just to sum it up then, what are your recommendations? I mean, we are about to go into a fourth wave. I'm not sure what the implications are, whether we'll get to a lockdown, but I want you to just talk about the importance of health service integration. Firstly, the importance of maintaining services, but then the integration between COVID-19 and TB so that we don't miss any patients. There's another medical condition which is common in HIV, PCP, for example. If an HIV positive patient presents with PCP, I don't think it's easy to differentiate, the two diseases. And health workers, have to always have that at the back of their minds, that these two conditions might need to be managed together. But yeah, at the public health level, What are your recommendations around the integrated approach to how these conditions, HIV, TB, PCP, COVID-19, because it's quite difficult to differentiate the two clinically at some point? Thanks.
So I believe the key thing is a holistic approach. So you'll be having a differential diagnosis, and it's only fair for you to investigate the case. When you are seeing that particular patient, you can just investigate. And I love that you are mentioning an important factor of integrating these services. So we know that, for instance, a COVID is you're not just treating a case, you are treating a patient and everything around that particular patient. So we can look into expanding capacity in terms of our diagnostic and treatment, and to ensure that when you see a patient, you roll out from one condition to the next. And it's even okay to run those tests parallel. So you can run your TB screening test while we're also running your COVID-19 screening or even diagnostic test, just to ensure that we cap the spread and we manage them as early as we can.
Great stuff. Great stuff. No, thank you. Thank you very much. I think I don't have any more questions. There's more questions for you on the panel. Dr. Sekule, you may take it from there. And I also saw Dr. Magagula, who was trying to join in. I think he has a network issue, so we can pose some of the questions if he successfully logs in. Thank you.
All right.
The important thing I forgot to mention is that the key thing is vaccination. We need to encourage these patients to vaccinate. And we all also know that it's okay for everyone to get both vaccine, your flu vaccine and your COVID-19 vaccine. But we know that the vaccine actually prevents them from actually having your COVID-19. So if they come for their TB screening or their TB treatment and their ARV treatment, we can always encourage them to get their vaccines. If they vaccinated way above 6 months, we can advise them to get their boosters, just so that their immunity is robust and ready to fight the infection in case they get an infection. So in that way, we ensuring that we at least have to be dealing with your HIV and your TBs and your diabetes and all other issues, not COVID adding onto that burden.
Great stuff. Thank you. Dr. Sekule? You might be having a challenge. Okay, Dr. Magagula,
thank
my
you.
brother. Okay, Sekule, just wait a bit. Dr. Magagula, are you back?
Can you hear me, Dr. Mawela?
Yes, I'm back, Elias.
Yes. There was a question. Sekule, few seconds. Yes, there was a question posed which I had to reply to around what is the probability of congenital COVID-19 in pregnancy. I did mention that in your previous presentation, you did cover that. There was a case definition as well to say at what point would you say. You also mentioned issues of doing placental biopsies or what, I can't remember. But yes, you may make a comment, Dr. Magagula. Thank you.
Okay. Well, so far, there is suggestions, from very small studies with very small population groups that suggest the possibility of congenital transmission of COVID, but there's no solid evidence. So at this point, there's no compelling evidence that there can be a congenital transmission of COVID. Yes, there is a criteria that we spoke about on the previous discussion that would actually qualify a patient as having a congenital or vertical transmission of COVID. But so far, there's no compelling evidence to suggest or support that.
Okay, thank you. Thanks, Sekule.
All right, thank you, Dr. Mawela, for that question. Dr. Ngobile, thank you so much for answering. Billy, welcome back.
Thank you, Doc. Thank you.
Yes, just a quick one. A woman married to an HIV positive man and want to conceive. What are the steps?
Okay, so the steps there, obviously they need to see their gynae for preconception care. So that preconception care, as we said, the partner, the male partner needs to be present. We have to confirm that the woman is indeed HIV negative, because we do get serodiscordant couples. And then we have to check the viral load of the husband or the partner, make sure that he's virologically suppressed. And obviously then they will therefore be attempting conception without the use of condoms as they are trying to conceive. And that then becomes important for them to use PrEP, so pre-exposure prophylaxis or Truvada. And ideally, to ensure the higher chances of conception, the gynae might consider starting them on ovulation induction. So, and then they can actually time their intercourse at the time where she's actually likely to ovulate. So it's just to make sure that the partner is virologically suppressed. We know that the chances of transmission under such circumstances are even less than 1%. And then the woman can actually be then on PrEP, and then the gynae will probably suggest ovulation induction, so that at the time of intercourse, it's the time that they are likely to actually have a conception.
Well, thank you. Thank you so much. That was very clear and loud. There was a question from the chat. Another quick one. They say a baby born to a positive mother who's positive on ARTs, the mother stopped the ARTs citing that they make the baby sick. How do we approach that?
Okay, so the mothers are classified into high risk and low risk. So your low risk mother would be the one who is virologically suppressed. She's taking ARVs well. She's been on lifelong ART. And then that particular example is the one where it's actually high risk and the baby is likely to have vertical transmission from the mother. And the other issue is that she's been on ARVs and she has now stopped. So there's a chance that there could be some resistant HIV that is now actually being selected. And therefore, the type of prophylaxis that the baby will get and the duration thereof will be appropriate for such circumstances. And there is a guideline of infant prophylaxis, which is, quite detailed. I wouldn't want to go into specific details, but then they would get AZT and NVP and, issues around breastfeeding and all that will have to be discussed.
Okay, all right. Thank you. Thank you so much. Nobile Ngoma.
Yes, I'm here.
I had to get back to you with this one. It's related, Dr. Billy, I want you to put your words as well in this one. It involves both of you, COVID, HIV, and pregnant women. They say after how long, after COVID vaccination, an HIV positive woman can conceive? When is it safe? Is it safe?
So COVID-19 vaccine has no association or interruption in terms of your ovulation or your reproductive health. So you can get your COVID vaccine when you're pregnant, you can get it when you are planning to be pregnant. So no one should be scared of having babies. Actually, we had people during the clinical trial 3 that fell pregnant during that study when the vaccines were even still tested during the Pfizer clinical trial. So that just tells you that, yeah, no one should be worried about pregnancy when it comes to COVID-19 vaccines.
Oh, okay. Thank you. Thank you so much. Dr. Mawela, do you have any questions? Dr. Buitumelo, I still there have one more question for you. Maybe you should take hands, Dr. Mawela. I see 3 hands. Tulimnisi, Mama Maho Khodi Mama Bolo, Siasanga Lengo. Can we just make sure those are true hands? In the meantime, when Dr. Mawela is verifying those hands, Dr. Buitumelo Pakati. Dr. Buitumelo, you need to unmute your mic.
Aye.
They say that CD4 count in a patient on ART affect the breast cancer presentation and survival. CD4 counts in relation to breast cancer presentation and survival. You need to unmute your mic. All right, thank you.
Thank you for the question. So what we know is that most of the breast cancer patients who are also HIV positive, we've noticed that the studies that are there, they've actually shown the median CD4 count of like more than 350. So because the CD4 count is like more than 350, we did not really see the actual impact of low CD4 count on the overall survival or even the disease-free survival of breast cancer.
All right, thank you. Thank you so much.
Dr. Sekole, on that note,
follow up to that?
Yes, Dr. Pakati, I always want to use your name. I hope that's fine. Yes, just as a follow-up, we do know, for example, with other cancers, right? that the guidelines would require us to initiate patients on ART before they are referred even for treatment and assessment and so on. What we usually have a problem with is that we would start ARVs and then we have a clinically deteriorating patient because of this exaggerated immune inflammatory response. It's called IRIS. Especially with Kaposi, patient would have one lesion, you start ARVs, they come back with 10 lesions, and you are stuck between, starting ARVs and referring to oncology. It's a question to ask whether in the breast cancer context and HIV, have you seen patients who are started on ARVs and they have like the lesion, because maybe it might also be linked to the fact that maybe they present with advanced disease because mainly we started ARVs and there's this huge immunological response against these foreign cancer cells. I'm not sure if that is documented in breast cancer, and what's your take on it? Thanks.
Thank you for that. There are three things that I could deduce from what you said. So let me start with the first one regarding the CD4 count and other malignancies. Remember, like that's now they had to categorize the malignancies into the AIDS-defining malignancy and non-AIDS-defining malignancies. So obviously, low CD4 count will definitely affect the AIDS-defining malignancies such as Kaposi sarcoma and cervical cancer. But for the non-AIDS-defining malignancy, that was not the case. Point number two, have we observed a situation whereby a patient has just started ARTs and then maybe the tumor progresses? We haven't observed that. I don't want to lie. It would be nice also to hear from the oncologist if maybe like have they observed that. What was the third thing? I forgot.
No, I think it's exactly the last one. It's probably clustered in the question around whether this exaggerated inflammatory response is something that has been observed with breast cancer. So yeah, so thank you very much for that. Thanks.
Awesome.
Obile, there is a question around vaccination and whether HIV viral loads may be unsuppressed and going up. Would you like to make a comment around that? It's by Dr. Chwewu there. Thanks.
Can I please get the question? I'm not sure I follow.
Okay, I will read it as it is written. It's written, does vaccination affect the viral load in patients who were previously virally suppressed?
In HIV patients, HIV.
Yeah, HIV patients who are previously virologically suppressed. Thanks.
Oh, not at all. Remember, the virus, the vaccine is not made out of a virus, so it has no effect on the viral load itself. It has no effect on the HIV viral load itself. So no, there won't be any effect in that case. So the only thing we worry when a patient is especially immunosuppressed, we say they must check with their physician before they get a vaccine, is because you need to ensure that clinically they can stand for the side effects. So you might see severe side effects to adverse events to people that their immune system is so down in a way that they hardly could stand for side effects. So that's the clinical assessment that needs to be done if a patient, even if it's not viral lower, the viral load is not lower than detectable, but are they clinically fit enough to stand for the side effects, the normal common side effects that we know that will result from a vaccine?
Yeah, no, thanks for that. The only addition I can add is that historically, we do know that patients who are fully suppressed when they are vaccinated with all sorts of vaccines that are currently available, they do get what we call viral blips, Dr. Chwewu. So they might get a temporary rise in the viral load, but not in excess of 1,000 copies. And when you repeat it in a few months' time, they should fully suppress at that point in time. That is quite a well-documented phenomenon, and it has to do with this quiescent DNA, viral DNA that lies quiescent in the nucleus of our CD4 cells. So during mitosis, you get now a facilitation of the viral replication and so on. So it's quite a well-documented phenomenon, but in the context of a COVID vaccine, it's something that probably needs further research. Thanks for that. Dr. Segula, I hand over to you to start to sum up some of the questions. And yeah,
Thank you. I do not have further questions, but I see a few hands. By the way, Dr. Mawela is an HIV specialist as well. Don't be surprised, you can take these questions. I see a hand of Siyasanda Lenko and Momo Khodi Mama Bolo and Patricia Lepele. Can you just check if those are true hands?
All right. Patricia Lepele, you may unmute. I don't think she will manage. Who's the next person there?
Sanga Lenko.
Okay, Siyasanga. You may unmute if your hand, otherwise lower your hand.
And Theatili Potter, allow Theatili Potter to speak. Theatili Potter.
Yes, Theatili Potter, you may make your
good evening, guys.
Good evening, Doctor.
I've been trying to get, my question answered, attended to. As I said, I don't know whether it was due to my unstable network, but I just wanted to ask, what in the event of a patient with acute kidney injury and on TLD, where tenofovir is contraindicated, what is the alternative regimen?
Dr. Magagula, are you asking your question in pregnancy, or you just want the general answer? Because I could try and
general.
answer. Okay, yeah, no, thanks. Yeah, so a few things. In acute kidney injury, one is to investigate why your patient has acute kidney injury. If it's due to dehydration, that needs to be dealt with. If your patient has been exposed to some of the nephrotoxic drugs, that needs to be dealt with, right? So whatever the underlying cause is, if your patient is in shock, septic shock, hypovolumic shock, cardiogenic shock, such that the kidneys are not being properly perfused, we need to deal with the underlying issue, because it's acute kidney injury, which might not be associated with any of the ARVs. In your assessment, basic things like your urine dipsticks, taking urine for your MCNS, if you think it's septic shock, collecting blood cultures and checking if there is a specific infection, assessing your patient in terms of some of the causes of chronic kidney disease, diabetes, hypertension, and dealing with all those issues. If the creatinine clearance remains above 60, then you don't need to make any adjustments, right? If the creatinine, the total creatinine exceeds 100, your creatinine clearance is dropping below 50, you might want to interrupt tenofovir and consider abacavir. Abacavir is the only NRTI which does not need any dose adjustments in the context of kidney impairment or renal impairment in that context. So abacavir will be your first option. Then if abacavir is not available, you have zidovudine. But if your creatinine clearance is below 30, you might also need to dose adjust AZT as well. Always discuss those kinds of cases with someone experienced in the HIV field, so that you can also get guidance on drugs, including lamivudine, which you would need to dose adjust. Your efavirenz or dolutegravir, those drugs are metabolized through the hepatic system, and you won't need to do any dose adjustments in that context. So it's quite a complex process, and it always depends on the underlying cause which needs to be addressed. Only adjust ARVs if you think ARVs are a contributory factor, or if your patient has a very low creatinine clearance, and then also pay attention to other drugs that are being used, which might be nephrotoxic to your patient. Yeah, so good. I think that one we have addressed.
Yeah, there's one hand there, Mama Bolo. Can you unmute your mic, Mama Bolo, before we close? It's
Mama Bolo.
all right, maybe it's a false answer. Thank you so much. Exactly 1955. We still have 232 in attendance, and I hope we have managed to answer most of your questions. If not, we'll try to answer them in our platform. These seminars will be made available to members of the clinical care platform. And to the host, Dr. Mawela, thank you so much. I believe this is our last session for the year. I wish we could continue, but we are tired. Thank you. We really appreciate the platform. Keep on doing the good work behind the scenes, the IT system, the IT, the softwares and everything. We thank you so much. and all the other workers of the clinical care platform. My panelists, Dr. Magagula, Dr. Pakati, Nobile Ngoma, I really appreciate you. Thank you so much. Thank you for making this time and availing yourself to our clinical care platform, as always, sacrificing your time to family to come and educate us. This was very informative and very educative. Thank you, we really appreciate. And to the attendees and everyone in attendance, thank you so much for making time to attend this platform. This platform is not a clinical without you. We urge you to attend even more, to become part of the members so that you can learn more and then we can share this information to everyone. From me, I am Dr. Njesekola. Thank you and good evening.
Thank you very much, Dr. Sigul. Dr. Magagula, are you still there? I want to close, but you need to reply to Anonymous because Anonymous talks about a virologically suppressed patient who needs PrEP. Can you clarify whether PrEP can be used in that context? Is he still there? Is he gone? All right. So I'll just, Dr. Magagula, are you still there? I'm not sure if he's still there. We can't leave without answering that question, and maybe the question needs to be rephrased, but let's just remember that PrEP is for HIV negative patients. So if your patient is virologically suppressed, there's no need for PrEP. In the context of couples, yes, there might be a need for PrEP for the HIV negative partner who might be exposed, and I think maybe that is the context. Unfortunately, Dr. Magagula is not here, but yeah, I hope we have clarified that. So yeah, thank you very much, everyone. Good evening, have a great evening. Just to appreciate our presenters and you, our audience, I want to encourage all of you in the new year. This platform is not limited, to anyone in terms of teaching and empowering health workers. If you do have a topic, if you do want to come to the platform and share your knowledge, do write to us and specify the type of topics you would like to share, and we will really give you a chance to share. And it's also not limited really to a specific healthcare profession, but for all health professionals with an interest to engage and to empower. Thank you. Enjoy your Christmas, enjoy your New Year, celebrate World AIDS Day tomorrow, and we hope to see you again in the new year. Thank you. Enjoy your evening.
Thank you. Good night. Good evening.
See you guys. Thank
Thank you, guys.